So we can welcome the speakers back up to the lectern here. And we have a few minutes for questions. So if anybody has any questions, please feel free to come up. Our one request is that you please speak into the microphone so that those who are attending virtually can hear.
So thank you guys very much. I don't mean to steer this back to PCD because you heard about this all morning, and I apologize. But we are often asked as the lung doctors, oh, you've diagnosed this single ventricle with PCD now. Should we not go ahead and do more surgery? To which we've all said, hell no, you need to go ahead. But should I be pushing for biventricular repairs versus univentricular? Because the 3 or 4 patients that had univentricular repairs for me with PCD died at age 4 to 5, and their lungs were really trashed by that point. And it's not usual for a PCD patient to die of respiratory failure until their 40s, 50s, 60s. So these kids were clearly outside of the bell curve.
Yeah, I mean, I think there were, in my mind, is the the surgeon who runs the complex single ventricle program in Boston. There were so many questions I had this morning, including that one of like, how should we risk stratify these patients differently? Like, makes me want to do inhaled nitric oxide on all of my single ventricle patients, right? And see what we're missing, because I do think the whole morning highlighted that there's a lot of risk stratification that we're not, at least from my perspective as a heart surgeon who's like taking these cases down one path or another. And I think you raise a very, very good point. And I think this all morning raised very, very good points that we have a long way to go to understand risk stratification. I would say our opinion is everyone should go down a biventricular repair pathway if their anatomy, and their heart function makes it feasible. So, but I do think, just as Ryan alluded to, it makes me think that we should totally change our threshold for transplantation in many of these patients, right? Because we play the same game that they play in Texas. We sometimes refer too late, and then we're behind the 8 ball where we shouldn't be. And I think that's a great example of a patient you could change their trajectory.
What we really need are some prospective statements to help us, because not every surgeon knows what you're doing at all of these centers, and I'm telling them there's no real precedent to withhold heart surgery from these kids due to PCD. I mean, they're treating it as like a cancer diagnosis.
Right.
And I'm like, no, that's not the case. And Tom Saba's had these same arguments with people, and it's happening everywhere without some very strong statements, even as little evidence-based as they can be, to say this should not preclude heart correction, cardiac correction. We need those badly, because it's happening very haphazardly all over the place now.
Yeah. But I think Caitlin has spearheaded an entire respiratory clearance program formally for heterotaxy patients, and I do think it underlines the importance of all of those things. You can't just say we should just do what we always did and hope for the best. I think we need to take all the very proactive steps to make sure these patients really do well if you know this going in. So.
Yeah. Thank you.
Yep, thanks.
Dr. Shapiro, you just set up a great question for tomorrow, where we'll be talking about our HRC3 toolkit, which addresses that very specific question. So, perfect.
Hey, everybody. I'm Sean Bali-Valigan from Cincinnati. This is all fascinating. One of the topics I specifically have as an interventional cardiologist been very interested in the size of the Fontaine conduits, as you said. We tasked it with one of my former fellows. Have you guys been using picographs at all, or have you thought about that? I'm sure you have.
Yeah.
Picographs, by the way, for everyone, is dilatable tissue fabric, essentially.
Yeah, the picograph is terrific. It's basically standard PTFE, but the nodes are bigger, and so when you stretch it, it will grow to 200% in the lab in theory. We have used some picographs, probably a handful. None of those patients have been dilated post. We are generally speaking a lateral tunnel center, and that is probably the one way to get over the growth issue. And I didn't get into the details, but the lateral tunnel patients have less increase in energy loss than the extracardiacs. What we just published is the extracardiac conduits. We usually put in, everybody in the country usually puts in 18s. What we've shown is that they, both the plastic size tends to regress over time, and there's always the obligate lining of fibrinous material. So the effective diameter, unfortunately, is less than 18, sometimes substantially less than 18. So the jury is still out, and no threshold exists. But you know, certainly, as you know better than I, you can, to some degree, balloon and stent these conduits in the lab. But we are seeing a lot of kids who the 18 put in infancy is correlated with early liver disease, and there's some 16s at our centers and other 16s that have come to us that definitely have early liver disease. So I think it's a huge opportunity in these single ventricle patients to be very proactive in a way that we haven't in the past.
Yep. And then one last question is, and this is probably pretty naive, but for Dr. Bruckner, would there be any, because as an interventional cardiologist, I do biopsy sampling all the time on heart transplant patients. So it may be a little bit, we'd have to think about the research ramifications of it, but do you think there'd be any utility in getting myocardial samples on heterotaxy patients to assess ciliary function? Is that something that we can consider doing?
Okay, thank you. Sorry, I was initially thinking post-transplant, which would be a whole entire symposium at IHLT. So, here, you want to answer that first? You probably do better. Okay, it's a great question. I think it's a really hard one to answer, as the field, I will be honest with you, in heart failure and heart transplant has gone away from biopsying as frequently due to the fact of, I mean, honestly, from my standpoint, I see a good bit of tricuspid valve injury, AV valve injury over time, and if in the wrong spot, if the AV node is injured or any other of the conduction system. So if we can reduce the harm that occurs during the procedure, then I think it's worth probably investigating further. But given the amount of data I can get now in terms of management from hemodynamics and MRI, I usually don't request a biopsy too often.
I just meant it more from a research standpoint. Is there any way to assess, say, in a non-transplant patient, right, when we routinely cath them?
You mean, are you
Yeah.
looking to see whether obtaining samples from either the cath lab or the OR for research purposes would help us understand the mechanisms?
Yeah, we just wanted to.
The answer to that is
up.
absolutely yes, especially the transplant.
Yeah, explain it.
Explanted hearts. And I know the PCGC consortium has been collecting tissue samples at the time of surgery, and especially John and Cricket Seidman have been working on a single cell RNA-seq or single nuke RNA-seq on those samples to better understand the transcriptional effects from the underlying congenital heart disease coupled with surgical and
tissue sampling,
tissue intervention. Currently, we are not collecting samples because the program is not recruiting until we get the good word to resume. And we haven't specifically looked for cilia defects because a lot of the focus has been on hypoplastic left heart syndrome and tetralogy of Fallot, so that we could have two groups of tissues that were internally comparable. But I think as we move forward, I'd be particularly interested in valves that were explanted or resulting in transplant, because I think that's where we're going to see a lot of the cilia-related pathology.
Yeah. I think a number of us who do imaging or care for these patients frequently observe a pattern of non-compaction in heterotaxy. And Dr. Bruckner, I've heard you comment on that previously, so I'm curious if you could offer some thoughts on that.
At the patient level, I don't have anything to date. At the research level, there is some suggestion that having no cilia early in development results in impairs the ability of the developing heart to form compact myocardium. So it's not quite surprising, but we don't have the numbers and the longitudinal follow-up to really look at that. Again, as you identify more patients and are able to follow them over time, especially their echo variables, that may allow some insight connecting genetics to things like non-compaction, is theoretically quite possible. But the answer is not there yet.
Any other questions? Oh, sure.
No.
Yes.
I was wondering whether have you seen either in the mouse models or in, for Dr. Bruckner, or in human hearts, have you seen, is there a significant level, a varying level of expressivity or sort of mosaicism at all that you see in within the hearts with heterotaxy in terms of the ciliary function, or do you see any of those changes at the sort of different levels of in the atrium, at the valve level, or is it kind of evenly distributed?
You mean you're looking at the normal hearts?
The patients with heterotaxy.
That we haven't been able to look at. We've started a single cell sequencing effort on mice with and without cilia to show some of the tissue level effects. And we've focused on valves so far, but there is clearly something in the myocardium also. But this is in early mouse hearts. We don't have the human samples, which in a way is a good thing, but I think that would be really helpful down the road.
Any other questions? All right, in that case, we'll conclude this session.